Bon, bonjour à toutes et tous. Merci d'être si nombreux pour cette dernière session du congrès. Cette session qui porte sur les nouveautés dans la prise en charge du trouble de l'usage de la cocaïne. Je suis Sophie Athéna-Chaperon, je suis psychiatre addictologue au centre hospitalier de la Côte Basque à Bayonne. Et j'ai le privilège de remplacer à la présidence Laurent KARILA, qui ne peut malheureusement pas être parmi nous cet après-midi. Alors, est-ce il sera présent en visio pour sa non, qui ne sera malheureusement pas présent pour sa présentation. Donc nous aurons finalement 3 intervenants, mais ce qui nous laissera un petit peu plus de temps du coup pour les présentations et puis pour les discussions. Donc ce sujet des nouveautés dans la prise en charge du trouble de l'usage de la cocaïne, c'est un sujet qui me semble d'une importance et d'une actualité particulièrement capitale dans le contexte de l'augmentation de l'usage de l'usage et de la demande de soins liés à la cocaïne au cours des dernières années. Je pense qu'on est nombreux à en faire le constat dans la pratique clinique et en ce qui me concerne tout particulièrement également au sein de l'unité de recours en addictologie à l'hôpital de Bayonne. Nous commencerons donc par une intervention d'Ivana OBRADOVIC, donc, qui est directrice adjointe et coordinatrice éditoriale et scientifique de l'Observatoire français des drogues et des tendances addictives, entre autres activités. Elle est également rédactrice en chef de la revue Tendance et de drogues enjeux internationaux de l'OFDT. Et elle lancera cette session en nous présentant un état des lieux de la cocaïne en France.
Tell us
Et
about
les enjeux de
the
santé
situation
publique
of
face à un marché
cocaine in
en plein essor.
France and the issues with public health in the face of a booming market.
Merci beaucoup, Sophie.
Thank you very much, Sophie.
L'invitation à ce
Thank you
colloque très
for
riche.
inviting me to this
Donc
rich
effectivement,
colloquium.
je vais vous faire un petit
Yes,
point
I
d'étape
am
sur la
going
situation de la
to
cocaïne
tell
en
you
France.
about the situation
C'est
of
des données que vous
cocaine
pouvez
in
retrouver
France.
dans un
This
rapport
is
qui est en ligne
data
sur le site de l'OFDT,
that you
que
will
j'ai
be
un petit peu
able
mise à
to
jour puisque
find
les
in
choses évoluent vite.
the side of our
Donc
observatory,
l'idée
and I
là, c'est
have updated it
de
because things
présenter un peu
are
en état des lieux
changing
des données de
fast. The idea
consommation de
here
cocaïne
is to
et de
tell you
cocaïne basée
about
slash
some
crack.
data on consumption of cocaine and crack. I'm going to tell you about the market, also the volumes, the concentrations, the confiscations, which are a good way to have an idea of the volume, even though, well, it is a partial indicator. And Sophie Marsin was telling us, so the part of cocaine that is confiscated can vary from 10 to 50%. So this is just one part of the real supply. And I will tell you as well about the health signs that are appearing and that tell us that we need to take care of cocaine users. So on consumption data, this comes from surveys from the general adult population by the OMDT and by Santé France. So we see that the experiences with cocaine have increased since the years 2000. And we have moved from 2% of people who've experienced this to 10%. So 1 out of 10 adults has already tried cocaine in life in 2023. And we see as well that there's a difference between sexes, 13% for men, less than 6% for women. So this experimentation, it's quite a poor indication because doing something once in your life is not an indicator for consumption. But at least it tells us that this product is more and more accessible. Then we will see that with other indicators. We can see that this rate of experimenting with cocaine is also broken out by age. And what is interesting here is that the most prevalent age range is 26 to 34 years of age. So it is not actually a dissemination that concerns adolescents. It's actually adults from their introduction in active life. And actually, one of the reasons why cocaine is used is because of its endurance, or because of its capacity to hold the workload. And here this data comes from the survey Escapade that was made to successive generations of adolescents that were interviewed. Here what we see is exactly the opposite that we observe in adults. Here we see a decrease in the experimentation of illicit drugs at age 17. We can see here 1.4 for cocaine, 1.4%. So it's quite rare, quite unusual. And there's a global stabilization of the use of stimulants actually in adolescents. Now let's go back to adults population. Now here we are with indicator of consumers, and the fact of having used the substance at least for the last 24 or 12 months, sorry. So you can see here the results for adults aged 18 to 64. Well, this has increased in the last 10 years, because you can see that in the shape of the curve between 2014 to 2023, there is an amplification of the use of stimulants in general, either cocaine, MDMA, or ecstasy, all stimulants. And now amongst adults as well, these use within the year, if we have a look at sex differences, we see that again, male are two times higher users than women. And we observe as well this increase after the COVID. Actually, after 2020, we have overcome the threshold of the million users in France. And we are at the top position after Australia, the Netherlands, the UK, and the US. So we are in 5th position, whereas 10 years ago we were in the middle of the list actually, and now we're just getting closer to these countries like the US, the UK. And here if we see the age ranges, the most prevalent age range is 26 to 34. And here you can see that from 35 to 44, there's the highest increase. And in the last 10 years, there's this acceleration of consumption. Now, if we have a look at the crack use and cocaine use amongst adults, we see now for experimentation, there's a later acceleration, 2017, and for the use within the year, there is also an important increase amongst men. Now, for the use within the year, we're talking about 0.3% of male users. So it's quite limited, but it's a trend that is interesting. So we see that for the use within the year, the trend or the curve is quite telling. Now again, by age ranges, we identify a peak for experimentation, and for the use within the year, there's this peak in the age range, 34 to 44 years of age, and this has actually been a little bit displaced. We have the data for 2014 in yellow, then 2017 in orange, and in red 2023. So we see that the peak in the year for the use within the year comes a little bit earlier in life than 10 years ago. Obviously, this booming of consumption can be explained partially because of the supply. And regarding the indicators of the supply, we see the confiscations actually, and we have a spectacular data in 2024, we have 53 tons of cocaine that were confiscated in France, which is the double of the year before. And what's interesting as well is that in the latest years, we used to have like 10 tons, and then we moved to 20 tons, and finally 53 tons. So the arrival of cocaine through maritime ways is quite a phenomenon here, and there are controls nowadays. There are lots of controls actually in the port of Le Havre, and we can see confiscations that may be stabilized in 1 year. But then drug traffickers find their way in order to place this cocaine, and it seems to be quite difficult to change that. And that level of confiscation can be explained because of the record figures of cocaine production at a worldwide scale. We're talking in 2023 about 3,700 tons in 2023. Colombia, Bolivia, Peru, but there are other countries producing today as well, like Venezuela and others. So we have a supply which is 3 times more important than in the previous decade. So we're talking about a change of scale, actually, in the supply of cocaine. And again, we can see that in terms of confiscation, there's an increase by 70% of the confiscation volume. And we see that as well in terms of consumption, because we're moving from 17 millions of users to 25 millions of users in 10 years, from 2015 to 2023. So 8 more million people using cocaine. And here we have the average price that also shows this accessibility of cocaine. We have this range of prices, and there are important variations. So that's why we talk about a range rather than an average price. And actually, if we talk about overseas cocaine, we are talking about a price in euros per gram which is lower than 50 euros. And what participates in this accessibility is the fact that cocaine can be fragmented, and you can even have less than 1 gram. So you can even access more consumers because of this low price. And well, we see here the price in bars, and the price is actually maintained quite stable actually up till 2023 even, and there has been a drop actually in 2024. We're moving to the symbolic threshold of below 60 euros. And well, not only the price is lowering down, but also the concentration of cocaine as the active principle is increasing. In France, we're here today on 72% of concentration of cocaine per gram. And in 10 years ago, or in 2011, the concentration was 40%. So you can actually have more cocaine in 1 gram, and then you can cut it and you can multiply the distribution. So this is also one of the most obvious evolutions. If we see the samples of cocaine that are collected by santé, we are talking about 100 samples. We are not representative of the market, but at least we can see that since 2022, there's an increase. We're talking about 30% of active principle. And recently, we have seen pure cocaine like 90% or even almost 100%. So this shows the saturation of the market and the abundance of the offer. And this accessibility is also shown in the ways of supplying cocaine. We had an online survey on users, telling them about how they would get their cocaine. And 2/3 of the users used to buy cocaine, and then 1/3 would give cocaine to their environment. And what's interesting and is that home delivery represents 1/3, even a little bit more than 1/3 of the declared modes of purchase. And the dealing is reducing, actually. Well, all this participates in or explains the accessibility of the product. Here we have a survey that talks about the prevalence of use, and here we have the representations and the opinions on public policies by adults. And what we see regarding cocaine is that there's a change in the social representation of the product. The notoriety of cocaine has progressed. So when you're asking adults about drugs that they don't know and that they can, well, what they can mention spontaneously, in the past, cocaine was not mentioned that much as it is today. So cocaine is actually part of the possible consumptions for the new generations of adults. And another indicator is perception and the risk of cocaine or the dangerousness of cocaine. So a lot of people consider that cocaine is dangerous only from a certain daily consumption. And well, this has doubled. So here we have the idea that this is a product that could be innocuous, and this has progressed actually. This idea has progressed amongst the population. Now, health risks are well documented. We are talking here about all the risks, the neurological, cardiovascular, respiratory risks, and there are people who are more qualified than me to talk about this. However, when we talk about indicators on care requests related to cocaine, we see that in the last 10 years, this request for care has doubled, and hospital admissions related to cocaine intoxication have been multiplied by 4, and the access to the ER because of cocaine use, well, this has multiplied by 3 in the last 15 years. So these are this is the data of the French public health system. So conclusion, again, we have this abundance of offer, this growing availability of cocaine, also because of the price, and new supply strategies that are constant and that are being, renewed. There's home delivery, there's fractioned sale, there's the diversification of the supply modalities, the capacity to buy cocaine or to get cocaine, also diversification of consumption modes, because there has been as well, new techniques to access cocaine, to use cocaine. There's also this access to crack. Before it was only developed in peripheral areas to Paris. And also we have all this health trends or healthcare resources trends that are convergent, and well, this makes us think about new targeted interventions. Thank you very much. Well, thank you. Thank you for this intervention, which was so clear and complete and so instructive. I don't know if there are any questions. If there are questions in the room. Well, I do have a question. Well, you insisted in this paradoxical data in, well, the evolution of the use in adults versus adolescents. And we had heard about this. And here, can we imagine a hypothesis for that? Is there any way to explain this kind of trend, of paradoxical trend?
Well,
Well,
in fact, it is relatively new. In fact, this generational fracture, we have generations split it between consumption amongst grown up and amongst the youth. We've seen this for cannabis, marijuana, tobacco, and alcohol. The results of a European survey led in 40 countries with youngsters age 16. France, which was heading the European table, now it is at the lowest, almost at the bottom. It can be explained thanks to several hypotheses. The change of sociabilities during adolescence, the fact that they, through social media, well, and less exits, less going out in the bars during the evenings. There's a change in social representations of drugs in general and the relationship with the body. This has been shown, the fact of taking care of themselves, paying attention to sport practice. Well, it is difficult to talk about youth because there are several profiles, whether you live downtown Paris or in the fields. We don't have the same conditions, but in spite of this, we can see these trends, these evenings with no alcohol, which are blooming. So that's a relationship with hygiene de vie. A sociological survey that we led at the OVDT before seeing this change in the levels of consumptions through stats, we could see that there was a degraded image of some products such as tobacco, which was perceived as a chemical product, so manipulated by the industry. There were some family narratives very well marked by deaths due to cancers for tobaccoism. So tobacco use a very negative representation of cigarette and of drugs in general. And now it is materialized, tangibilized through data. I will have to leave. I apologize for this a bit before 4 p.m., but I have to take a train. I will be available in case you have got questions. Thank you very much for this very instructive answer. Have you got any other question? Are there other questions in the room? Yes, we can take one more. Dr. Sage, psychiatrist in Marseille, have we got elements about the cat products as for cocaine? Well, we are going to unveil the results in very few weeks, and they show that there is not a huge evolution. Levamisole is heading the adulteration products, but this data will be soon unveiled. A bit of a spoiler of the colloquium at the Ministry of Health on the 27th of November, 30th anniversary of the device. Please, if you want to attend, please send us a mail. It is under preparation. We will present all these results of the two two devices that will be articulated from the 27th of November. Thank you very much. Another question? Yes, I had a question because you were talking of products which are purer and purer. Most of the studies say this, but when we visit patients individually, they tell us that products are less pure than before, whether it is heroin or cocaine, and that before it was better. Is it at the level of wholesalers? Maybe it is more chunked or more cut or less pure when it gets to the consumer. I come from Brussels. Do you have discrepancies vis-à-vis this purity index? Have you monitored this data? Well, indeed, you're right. We have to distinguish the different levels of markets. That's why I showed two slides about this, because when we do analyze the products coming from scissors, potentially we have a purity indexes, purity rates, which are higher than for those sold on the streets. Because collects have been done on products which have been delivered to the CARUD. Well, delivered, you understand me. This trend is rather coherent, and it is at the level of detail of retail products that we see the highest difference. There are more samples between 90 and 100% of active ingredients. It doesn't mean that they are very little pure products, of course, but this is the differentiation. This is the scale of products that we can find on the market, which has become broader. Hello, a question regarding the COOP projects. Did you find xylazine in or fentanyl in the products associated to cocaine? Is there an explanation of why we don't find this situation in France or Europe? As far as I know, I think we never had cocaine samples cut with xylazine. The xylazine, there was a sort of media fear of the arrival of the zombie drug in France. It was disaccredited. The same for Antanil in Strasbourg. There was a case, but the arrival of fentanyl in France is not documented. So these media fears are a bit enlarged. And it has then, for certain researchers, are much more powerful than fentanyl, but there is this focusing on particular specific products that we would be expecting in Europe, but about xylazine, there are no signals, as far as I know. Along the thread that as said, we are reluctant about, it is a raz de marée that comes from drug traffickers that impose a product on a market. That's why the explanation of the increase of cocaine is due to other factors, cartels, Latin American cartels, so that the American market was saturated in cocaine. They wanted to find new markets. Okay, but there is an increase of consumption because there is a demand. There are facilities of access due to deliveries after COVID. That is when this took off. These home deliveries took off after the pandemic, but we can see fishermen, fisherwomen using coke, truck drivers also. Well, They had told us plenty of things with the arrival of amphetamines, methamphetamines, but this never happened because it seems the European market doesn't want it, at least in France. As for fentanyl, etc., when there will be heroin of acceptable quality, and that is the case now, well, the street heroin and its quality has clearly increased regarding in comparison with the years 90. Fentanyl and others, in my opinion, there will be no demand for this, and the offer doesn't make demand. About cocaine, a little bit, there is such an abundance of offer or supply. Well, and for methamphetamine, there are no consumption in France except in the French Polynesia. That's a development of the production labs on the European countries. There are some signals in some countries, but they haven't arrived yet. We hope that they will never. No more questions? I've got good news. We will have the presentation of Laurent KARILA video conference that will just follow. He's professor of Paris-Saclay, psychiatrist, addictologist à Villejuif. He's the spokespeaker, president of Collégiale Addictologie ADHP, and vice president of the Collège Universitaire National d'Enseignants d'Addictologie, author of several works and podcasts within the frame of addictology and psychiatry, and who will tell us about the last progresses of pharmacological treatments in for cocaine use disorder. Hello? That's okay, that's fine. Go ahead, please. Hello, everyone. Thanks to the organizers. I'm sorry for not being here with you, but this Benjamin storm was terrific. I know you are enjoying warm weather in Biarritz. I'm sorry for not being here. We will talk about pharmacological treatments in the use of cocaine. So, from the interactome process, the exchange between proteins, what interests us are the transporters, dopamine, noradrenaline, serotonin, with interactions. And this is the story of this perturbed homeostasis glutamatergic within this type of addiction. We have a large type of system. This explains that there are very few pharmacological treatments that achieve something in cocaine addiction. Our main clinical targets, it is a real problem because we say with a drug we will be able to target all the targets, but maniac syndrome or syndrome de sevrage, depressive like 1 to 6 months, the craving cocaine with this negative reinforcement during consumption, cognitive troubles, they play a major role in the medical care. So we need several therapies, several strategies associated. There is a vector substance of some troubles and complications and cardiovascular complications. We should do stress ERM, neurological complications, infectious complications, as well as induced psychotic episodes, induced panic attacks, well, which are treated wrongly with antidepressants. Cocaine, we know it depends of the stage of use of the patient, but we know clearly that in chronicles, that's a major disorder in all the cognitive functions, and that it can go to atrophia of certain regions. It had been well described. Well, sorry, it seems we lost the sound. Can you hear me? Can you hear me? Yes, yes, you can keep talking. So, was I talking about the cognitive deficits? Yes, just 1 minute ago, 30 seconds. So, a disorder in chronic use with all those fears tact as for the basic intentional plan and executive one, and it can go till the atrophia of certain regions as described in 2012 with the prefrontal and temporal regions with an irreversibility, the clinical level to achieve abstinence or reduce consumption at maximum. There are some patients that manage their consumption, recreational use with no dependence. We know that the survey from 2012, they have memory troubles. These cognitive deficits can be stabilized with treatment after 5 or 6 months of abstinence. There is also a literature about predictive factors of the outcomes of treatment that have to guide us in our medical treatment. The predictive of relapse or abandonment of treatment, young who consume from since a long time ago, they have created a level of craving very important with impulsibility and predictions with less important symptoms of withdrawal, much more self-efficiency, and they get involved more in the care programs. As for the comprehensive therapeutical plan, syndrome de sevrage, the notion of danger, I believe in these urgency services, emergency services, all this has to be integrated in a huge program. And as for the objectives of consumptions, the consumption is absolutely impossible with cocaine, even though there are people who pseudo control their consumption, but we target reductions, which is a major variable in the current studies with the pharmacological treatments to reach abstinence, the best possible results. Laura Volcox described it very well. There are evident benefits to in reducing consumption, decreasing overdoses risk, reduction of transmission of infectious diseases, less road accidents. When we see the meta-analysis on these questions and in the samples of patients addicted to cocaine, the idea is reaching at least 75% of the mean decrease of urinary toxics. The reduction of use is linked to an improvement of severity of depressive symptoms, the craving, as well as several functional domains. About pharmacology, no AMM, the signals of efficiency are signals in subgroups, and mostly they are linked to community reinforcement, management of contingencies. I'm talking of this since 15 years ago, and the approaches that we find, the overviews are substitutives. We are on the idea of immunotherapy with the development of vaccines. There was a bloom at the beginning of the year 2000 with the TACD vaccine against the cocaine. It blocked the antigens cocaine with the vaccine and cocaine. And in 2014, results in phase 3 showed that it didn't work that well. There were two antibodies which were too variable on the subjects, and there were harms of overdose, intentional or not. These vaccines were stopped, and there were other options to boost this immunogenicity with the development of other vaccines, other proteins. I put plenty of names on the slide, but there are several clues that are assessed to boost this immunogenicity. So they are ongoing trials and with different candidates. This pharmacokinetic approach, there was the idea of developing different types of antibodies, monoclonal antibodies, anti-cocaine with animals, with interesting results with animals. Another aspect of this kinetic approach, genetically modified enzymes. There have been works since 2018 developed by the team of Chen, sorry. And these are very interesting studies at animal stage so far, with a long biological half-life on mice, and this enzyme could prevent the physiological effects induced by cocaine, inducing on the traffic of transport of dopamine, the principal acid of dopamine. As for the dynamic, we prescribe drugs, aura MM, which have had signals in literature with exchanges in the congresses and conferences, cross-professional exchanges. The first pharmacodynamic approach trend is the N-acetylcysteine, which will target the GLT1 receptor. And when we take literature, what comes out is that we could use it at 2,400 milligrams per day. We can prefer it at this dose. These are the signals we have, and ongoing works of neuroimaging show that this N-acetylcysteine would be beneficial at the level of the brain. Topiramate is another clue. There were recommendations of NSM not to prescribe it for women, as well as prescriptions just by specialists. As for RAMM, once again, with the cognitive and behavioral approaches show results with this decrease of consumption, the reduction of craving, depression, comorbid depression, alcohol and cocaine. At the weeks 1 and 4, they fade out after 12 weeks. As for crackers, surveys were a bit discrepant, and there are no results on methadone and alteration of cognitive with patients on and TRSO with addiction to cocaine. To combine the drug approaches, because it is trending now. There is a survey in the labs combining topiramate and phentermine, showing a stability of the combination, showing also a self-administration of combining this approach. So some signals to combine these approaches, beta-matergic with amphetaminic approaches. Dilsulfiram was also a clue which was very strong in 2015-2016 with several surveys with posology of 250 milligrams per day, that disulfiram would act outside the effects on the alcohol. There would be no deleterious effects at the cardiovascular level that could increase this, but we stay in the second line with patients with alcohol troubles. Some patients boost their alcohol consumption, whether by excess or dependence. As for other therapeutical approaches, we have the agonist of the alpha noradrenergic receptors. There are trials with doxazosine alpha blocking showing the decrease of stimulating effects of cocaine and trend to the reduction of craving. A pilot survey over 4 weeks with doxazosine, reduction of use of cocaine. Also trials with piperidine, galantamine, 8 milligrams. Carol, who passed away, unfortunately, a few years ago. What do we have in the arsenal? There are trials with ketamine, and as for the receptors, NMDA, they play a major role. There has been a controlled randomized trial with 150 patients, one sole dose of ketamine combined with meditation played an important role for the diminution of craving and augmentation of abstinence rate. For ketamine, apart on meditation for some networks, and the ketamine group had a good abstinence rate until 6 months. The psychedelics, I will not tell you about because you have a great presentation afterwards, but it is a potential clue for the future. I am interested since in the action of the clavulanic acid. This acid plays a major role on the metabolic glutamatergic vias. The first trials was in lab with a diminution of the self-administration of cocaine, an interesting work on MRI functional showing that clavulanic acid could decrease the effects involving the use of cocaine. And the other clue for the future, this clue of glutamate with a reduction of the number of days with no consumption of cocaine, a reduction of the metabolic agents of cocaine that showed the potential efficiency about addiction to cocaine. And substitutive approach, well, it is what we do with nicotine, with opioids, and the idea would be of using amphetamines. And there are clues with D-amphetamine, dexamphetamine, playing on the transporters of the amine particular 2, and the amphetamine would decrease consumption, but with two important addictive components. The L-desoxetamine 40 to 50% in the first pilot trials. We have trends to the reduction of consumption, trends for a good safety, a good employment tolerance. Other amphetamines, the salts of amphetamine to prolong the liberation with a TCC that could promote a more prolonged abstinence in severe consumers. Also, the results in led to promotion of abstinence with a combination of what we use could read in red. Modafinil in 2005 potential clue of substitution agonist substitution because it goes to the transporter of dopamine. The first surveys of 2005-2006 showed magic results, reduction of craving, euphoria, maintenance of abstinence, better results amongst men, non-dependence to alcohol. There was a work of neuroimaging. We were a bit disappointed because this mode didn't have the wished impact. Two other studies are ongoing with the idea that this would be a potentially usable drug to prevent relapse. So only on patients with ADHD, well, tamoxifen, they have no effects on cocaine consumption, but they have effects on the ADHD, which will reduce the effects of cocaine. It is another approach, different. They focused on the craving only as the main vector, and they did a complete listing on which drugs could decrease craving in cocaine according to the time lapse. They split it in short and medium term. Short term, up to 7 days. There are signals that they retook literature. There would be signals with choline and fenfluramine. If we go beyond, well, you have a huge list here listed, and we can find certain molecules that we have just discussed about. I also always like this slide. We know that antipsychotic for the indication addiction to cocaine, it doesn't work at all, except for topiramate. All the dopaminergic the same, antidepressant the same, and all the TSO the same, except, well, in their own indication with problems with opioids. We have seen some troubles with prescriptions. I received a report from a patient full of psychotics because we needed to block dopamine, whilst we know that this is not the point. It is absolutely overcome. Brandt had done, she said that we needed to phenotype our patients. It works in subgroups, and according to the pathologies associated, we need to target our treatments, which are a small element within the huge program of care. There are patients with addiction to cocaine, comorbid, and alcohol. Topiramate and sufiram could be prescribed as an option, and for the opioids, topiramate and glantamine. There were attempts to have the type of antidepressant that would work better, apart from valenfaxine, which has shown signals, but these are episodic. We have to couple our approach to psychotherapeutical approaches in red, what was said in 2010, and in green, what should be done in reality. Because when we retake all the analysis of literature, these meta-analyses of 50 clinical studies, the most efficient treatment, short-term and long-term, is the management of problems, as well as this reinforcement of community approaches, social education approach, patients, etc., as well as the community reinforcement. The idea is of reorganizing the life of patients with gratifying activities, which would be more gratifying than consumption. Combining then therapeutical approaches, there are drugs that can help psychotherapy have to be put forward in the frame of a very comprehensive program. Thank you very much for your attention.
Merci beaucoup pour cet état des lieux.
Thank you very much for this review. It's been exhaustive, and well, I guess that we all have some questions. I don't know if you agree, Laurent, if we can keep the questions to the end of the session. Yeah, I'm afraid I will not be here at the end of the session. Okay, well then we are going to ask questions now to Laurent. Hello, thank you very much for your presentation. I have a question. When you said that it was possible to have a controlled use of cocaine, on which is this observation based? Is it according to your clinical practice? I mean, could there not be a bias of the clinician? I mean that you get the problematic cases. Have you studied the works of Carte in the US, who has worked a lot on the scientific position of cocaine? She has worked a lot on this. Yeah, I know that I don't believe very much in this. I know that I have the label cocaine since 2009 in my clinic, but I have patients who come to us and they presumably control their consumption. Now, when we analyze these patients a little bit more in depth, I mean, the complementary client who's completely exhaustive, and he tells us about recreational use, we can find cardiovascular major abnormalities, or we can also find these cognitive signs. So, yeah, it's okay to have this idea of control, but there's going to be some kind of somatic harms and psychological harms or alterations. Thank you very much for your presentation. In one of your slides, you were saying that we shouldn't prescribe, well, topiramate, anti-epileptic drugs should not be prescribed. Yes, as I said, this anti-seizure medication should not be prescribed apart from topiramate. There are restrictions to prescription, because when we prescribe this medication, after that, the patient can suffer from crisis. Even at the end of the treatment, they can suffer from seizures once they have stopped. Well, I have never seen that. I do not know. I cannot give an answer to this. And now, regarding the Federal Swiss Council recommends medicalized cocaine. Is this a solution that we could contemplate for users who are not inserted, because it's very difficult to create an approach for them? And when we talk about the psychosocial approach, after 2 or 3 meetings with the patients never comes by, and then when they come by, they're always in an emergency and there's no time to work on something a bit more in depth. Well, there have been works on this since the end of the years 2000 on this psychosocial approach. It would be an option for some particular cases of patients who resist all kinds of treatments. But again, the psychosocial option or the contingent management option should be put in place since the very beginning, because it does help patients a lot. I work with this kind of patients, and then it's difficult, you know, if they're heroin addicts, heroin users, it's easier, but for crack users, it's very difficult to catch them and to make them come by. Yeah, this would be an entire topic in itself. Daniel Giulino from Geneva. And first of all, well, you know that trains in France, the railway system does not work well in France. Yeah, but this is no excuse. We're all here in the end. And now, well, my question was about cocaine replacement treatments. We're thinking about this in Switzerland. There are many initiatives, and we're preparing a protocol. There's no guarantee that we will succeed, but there's a probability with medicalized cocaine. All right. So the question is how to do that. I mean, cocaine exists as a medication, and it could be an off-label. All right. And again, no excuses. You should be here in presence. Any other questions? I do have one last question regarding hydrolyzed cocaine, long-acting. We have talked about the risk of overdose related to vaccination. So is this risk present for this hydrolyze? Well, in animal studies, we've shown that long-acting hydrolyze protects animals who were addicted to cocaine, and it would inactivate immediately cocaine. With the action of this enzyme, all these metabolites go through urine. So this is a very good way to, or clue to move forward, actually. And this has been made by Chen's team. So we will see the results of that. We will see what can happen to humans. So it inhibits the action at the brain level, but also at a cardiovascular level. Yeah, it inhibits the action immediately. There's this self-administration of cocaine by rodents. And when they are analyzed, there's all these metabolites that are found, and there is no effect, no euphorizing effect, no psychostimulant effect in these rodents. All right, thank you. Well, it seems quite promising, this hydrolyze. And thank you very much for this presentation. Yes, I wish you a very beautiful end of Congress. Well, I suggest that we move to the third presentation by Peter HENDRICKS. Peter HENDRICKS is a clinician psychologist at the University of Alabama in Birmingham. And he is also responsible for the review of psychedelic medicine. And he's just finished a randomized trial on the use of psilocybin for the treatment of cocaine use. So he's going to present the results today. Thank you.
Okay, thank you. Hello. So I'm going to start my presentation with a positionality statement. This is a statement that is common in the qualitative sciences, and I feel this is probably important for me to make here because it's often assumed that in the world of psychedelic science, there's a fair amount of bias in how the science is conducted, and that could be the case. I do think that psychedelics are held to a fairly high standard. I think they should be held to a high standard. I think everything should be held to a high standard. But I find that this statement is a good way of answering a number of questions that have come up over the years, some of the most frequently asked questions And probably the first, most frequently asked question would be why I was interested in this line of work in the first place. And I think over the years I've learned that what people are really asking me is, am I someone who has used or uses psychedelics? Am I personally very fond of them for some reason? And I understand where that question is coming from. There's a long history here in association with the counterculture, and I think people would like to know if I conducted this trial as an objective scientist or as an enthusiast of psychedelics and someone who sought out to show that psychedelics can be helpful in the treatment of cocaine use disorder, rather than attempt to do so in an objective way. So let me just say this. I first came into contact with this research in 2006 when my dissertation, which was a study on smoking, was published in the same issue of the same journal as Roland Griffith's now hallmark study of psilocybin in healthy volunteers. And I was quite taken with the study. And you might wonder why. I'll take a step back further. This is somewhat personal, but my mother, who's from very rural North Carolina, who was raised Southern Baptist, she converted to Catholicism when she was in college. So I was raised by a Catholic convert, and France is a traditionally Catholic country, so you might understand what that would be like. But we were a pretty serious Catholic family, and I went to a Catholic high school. So when I saw Roland Griffith's study on psilocybin, my first thought was, here's a drug that can bring about the same sort of experiences that I read about in high school. Teresa of Avila or Catherine of Siena. Isn't that amazing? It was not informed by any prior use of psychedelics, but I certainly did feel like a spiritual experience could lead to a change in behavior that would be beneficial, and I was certainly curious to explore this further, in part because, as many of us know, the treatments that are available for addiction, substance use disorder, and cocaine use disorder are not very effective, and I feel like we owe our patients to really explore all options available to us. So I say then before I begin that therefore I am not someone who has used psychedelics. I don't use them in my daily life. I do use caffeine. I feel like that's important to note, but not enough today. Okay. How do I advance this slide? Oh, there we go, great. Okay, so much of this has already been covered. I'll go through these slides quickly, but there has been a rather dramatic increase in cocaine use recently, especially during the COVID pandemic. There are 23 million users worldwide, or at least as of 2022 there were. Fatal overdoses have increased quite substantially and alarmingly, largely because fentanyl has found its way into the cocaine supply. And as I mentioned, there are no yet effective or at least approved pharmacotherapies for cocaine use disorder. Only contingency management works rather reliably, and the odds ratio there is 2.1. The issue with contingency management, especially in my home country, the United States, many people don't like the idea that we would pay people to do something that they should be doing otherwise. So there are some barriers to its implementation in clinical practice. Also, as many of you probably know, if you've worked with contingency management, once you stop reinforcing cocaine users for abstinence, they typically start to use again. Much of this was already covered. I was very interested in the specific epidemiology of cocaine in France, but as noted, there's been quite a resurgence or increase in cocaine use recently, which is quite alarming. Tied for the highest in Europe, I believe, with the Netherlands. Okay, so a bit about this trial. This was a quadruple-blind randomized clinical trial. What does that mean? That means that the participants, the therapists, the assessors, and the statisticians were all blind to treatment assignment. So we tried to go about this as rigorously as we could. I think there is an issue with functional unblinding or maybe unmasking bias in the psychedelic field, though I don't think this is unique to psychedelics. We'll talk about this in just a little bit. But as a general overview, we first saw people for two what we call pre-screen meetings. And for those of you who work with cocaine users, you probably know they're rather notoriously unreliable and rates of dropout are quite high. So before we really began the psychotherapy process, we wanted our participants to show that they could reliably attend appointments. At that first pre-screen appointment, we inquired or assessed past 90-day use of cocaine. And at every subsequent appointment, we would have assessed cocaine use since their last appointment. And we used the timeline follow-back interview to do so, and we verified abstinence with urine drug screens. So we collected urine every time we saw participants. So there was this pre-treatment phase, after which there was what we called the preparation phase. So we were quite literally preparing our participants for a psychedelic experience, for a psilocybin experience. And this was client-centered and focused on both psychoeducation and essentially establishing therapeutic alliance and rapport. We also provided, throughout the study, a manualized and empirically supported cognitive behavioral therapy. We then administered the drug in a clinical research unit, so this is an outpatient medical research unit. We administered 25 milligrams per 70 kilograms of psilocybin, which is a big dose, versus 100 milligrams of diphenhydramine as our placebo comparator. The so-called integration process begins 48 hours after the drug administration session. I wish there were a better word. I think it seems like we're doing something that you can't quite describe. But in essence, I think what's happening at this point is natural problem solving. So if you had any insights during this experience, is there a way that we could apply these insights to your life going forward? So for instance, someone might realize, I need to stop spending time with those friends of mine who use cocaine. I need to start spending time with my friends who don't. We might work around how they might do so going forward. We provided 4 more psychotherapy sessions before the end of treatment, and then there was assessment only 90 days after the end of treatment and 180 days after the end of treatment. Now, I was interested in 3 primary outcomes that were related but different. One was percentage of cocaine use days, or the inverse, in fact, percentage of abstinent days. One was complete abstinence after drug administration, how many people reported that they stopped using cocaine and never used again. And the third was after drug administration, time to first cocaine lapse. A bit about our demographics. The one thing I want you to take away from this slide is that we had a sample of lower income, lower socioeconomic status, primarily African American cocaine users. This is notable because most studies in the psychedelic literature to date have enrolled very high income, predominantly white, and more educated participants, typically with a rather extensive experience of previous psychedelic use. If you look at the very bottom of the slide, you'll see that of the 40 participants, only 3 had ever used a psychedelic in the past. And of those 3 people, 2 were men in their 50s who vaguely remembered having used LSD when they were teenagers in the 1970s. So these were not people who generally came into the study with strong positive expectations about psychedelics. They hadn't read Michael Pollan's best-selling book. And in most cases, people would tell me that they thought the idea sounded crazy, but they were willing to try anything at this point. Oh, here are our adverse events. There's a lot to take in here, but what I want you to take away from this is that our adverse events were expected in all cases except for one spontaneous orgasm, which the childish part of me thought was funny when I learned of. But there were no unexpected adverse events, and all were transient, mild, and resolved with no sequelae. So some process variables. These are fascinating to me for a number of reasons, but one being that cocaine users are very likely to drop out of treatment before it ends, before it's complete. The one meta-analysis would indicate that almost half of cocaine users will terminate treatment early. And what we found is among those who were administered psilocybin, no one dropped out of treatment, whereas 5 of those who received placebo did. We also had, generally, as you can see, better retention in the study among those who received psilocybin relative to placebo. Now, what about treatment guess? So this speaks to functional unblinding or unmasking bias. So of the 20 participants who received psilocybin, 18 accurately guessed they received psilocybin. Of those who received placebo, however, half, or in fact more than half, incorrectly guessed that they received psilocybin. I think this is important because the data to date suggests that generally your drug placebo difference or your psilocybin placebo difference will be greater when participants are accurately able to determine that they received the placebo. I think these data suggest that we had a placebo that worked. It worked in part because our participants did not have prior experience, for the most part, with psychedelics, so diphenhydramine was convincing. I'm not especially concerned about unmasking bias, at least from the participant perspective, because I do think we had an effective placebo for our participants. But what about the therapists? Now, I was the primary therapist. This study was funded with a very modest budget. This was funded before psychedelics became as popular as they are. And I was able to accurately guess who received what 39 out of 40 times. So I was correct every time but once. I'll tell you about that one person for whom I was incorrect here in a little while. And the secondary therapist who was in the room with me, there would have been any number of secondary therapists, but the secondary therapist was also accurate in their guess 39 out of 40 times. I think this speaks in part to how unique psychedelics are, how unique the effects are, how difficult it is to truly blind these studies. And I think going forward, as you look at the main results, we have to consider whether there was something that either I, as the primary therapist, or the secondary therapist did to introduce a demand effect, if participants perhaps responded in a certain way going forward based on what they thought we wanted to hear. It's not clear to me. That could have been the case. So some subjective effects. So the first measure of subjective effects with psychedelics is the challenging experience questionnaire, and this captures some of the more difficult experiences that people can have. And here you can see that the participants who received psilocybin did indeed report more challenging experiences than those who received the placebo, and the effect sizes were large. But I think it's important to note that there are adjectival anchors for each one of these numbers, okay? So for those who responded between 1 and 2, they were telling us that these challenging experiences fell somewhere between so slight they could not decide or slight. And in the case of grief, you'll see that the average score fell just below slight. So while there were some challenging experiences here, our participants did report that they weren't that severe. At least that's what they said at the end of their experience. Now, the mystical experience questionnaire captures the subjective effects that appear to be associated with therapeutic outcomes. So you might say that these are our biomarkers of response. We would like to see that these scale scores are higher to achieve the therapeutic outcomes that we want to achieve. And here you can see very clearly the scale scores were stronger or higher among those who received psilocybin relative to placebo. This is something that's been reported in many prior studies, so I think it's fair to say we're able to confirm that psilocybin behaved as expected in this sample. This is a questionnaire that was used by Roland Griffiths in his studies. We asked people to tell us how spiritually significant this experience with psilocybin was. And here you can see that among those who received psilocybin, received psilocybin, 6 said that it was the most spiritually significant experience of their life, with 10 saying that it was in the top 5. No one said the same among those who received placebo. No one said it was the single most spiritually significant, although there were 2 who said that it was in the top 5, which again speaks to placebo effects. So here's one of our primary outcomes: percentage of abstinent days. This is an outcome that we would like to see increase if participants are indeed responding to the treatment well. So what we see here is at the very beginning of treatment, at baseline, our participants reported using about half the time, every other day, on average, usually the only barrier being access or finances. During the pre-screen phase, we see an increase in abstinence, and this is a very common finding. When people enroll in clinical trials, they're ready to stop using or ready to change before you even ask them to, so to speak. People began to change to some degree, and during the preparation psychotherapy, we also see an increase in abstinence, but no difference between the conditions. After drug administration, we see this fairly substantial difference between the conditions, where those who received psilocybin reported more abstinent days across the study through the final follow-up relative to those who received placebo. And the effect sizes were quite large. We also, as I mentioned, assessed complete abstinence since drug administration. So how many people reported that they stopped using and they hadn't used any cocaine whatsoever through the final follow-up? And 6 of the 20 people who received psilocybin reported that they had stopped altogether. Nobody in the placebo condition reported this outcome. The hazards ratio in this case was 18 or so, but it's a fairly imprecise estimate given the sort of separation in these outcomes. And then finally, the survival analysis, so time to first cocaine lapse after drug administration. You can see here that among those who received placebo, there was essentially a much longer time that elapsed from drug administration to their first lapse, if they lapsed at all. So in total, those who received psilocybin used less cocaine after drug administration, were more likely to say that they had stopped altogether, and were more likely to go a longer period of time before lapsing. Okay, my last 2 slides are a little complicated, but I wanted to graph out individual response. And that's what these last 2 attempt to do. So this graphs change from baseline. So we looked at percentage of cocaine use when we first saw participants at intake, and we compared that to percentage of cocaine use from drug administration through the final follow-up. Okay, so if the bars go up, that means that people were reporting more abstinence. If they go down, that means they're reporting less. So what we can see here is that in general, those who received psilocybin responded well, but not all. Some responded better than others, and there were some who received placebo who also responded quite well. The next slide, however, shows a change from the preparation process. So we looked at the percentage of abstinent days that were reported after participants had enrolled in the study and were receiving psychotherapy and were receiving CBT that we know works. And we compared that to percentage of abstinent days after drug administration. So one way of thinking about this, if there are any gains that were made during the period of time where people were receiving cognitive behavioral therapy, were they maintained after drug administration? Again, if the bars go up, that means that there is more abstinence relative to that period of time before drug administration, but when participants were receiving cognitive behavioral therapy, if those bars go down, it shows that after drug administration, through the final follow-up, there was a decrease in abstinence relative to that period of time that they were receiving cognitive behavioral therapy, but no medication yet. And here you can see pretty clearly most of the participants who received placebo ultimately reported an increase in cocaine use, and this is a common finding in clinical trials as well. When treatment ends, the problem tends to rebound, but there were 3 here who continued to perform well. Most of those who received psilocybin, on their hand, reported more abstinence after drug administration than before, with some who generally seem to report no change whatsoever. Oh, it looks like I've ended right on time. I'm very proud of myself. Normally I talk too much, but I'm happy to take any questions.
Yeah.
Thank you, Peter. We're going to move to the last presentation, and we will have the questions just after that.
Last presentation will be by Florence VORSPAN about hospital care for crack users and experience in the northeast of Paris. Medical care and readaptation in addictology of hospitalière. She will address the prise en charge hospitalière hospital care for crack users in northeastern Paris. Thank you, Tina. Thanks to the organizers, it has been a pleasure to attend this session of ATHS. I'm very happy to be able to share with you my report in this session dedicated to cocaine. How our practices were modified by this users of crack in our hospital at the northeastern part of Paris. I think that I have no incompatibilities and for the disclosure. Something that that struck us as for dual pathology with psychotic symptoms were first raw with the outer patients as well as withdrawal patients. We tried to respond as better as we could to our demand. It is just next to Gare du Nord, and since a little I am in charge of a follow-up medical care center in Saint-Denis, where the medical care is, let's say, missing. It is a small hospital with a nice small garden in front. We are very lucky, not only for the venue, but within the department in which I am in charge of the outer patients. We have a service of internal medicine. They do only withdrawal hospitalization, which is a program in a classic way, as well as the medical care of polyvalent medicine, including these patients from um, emergency unit. Some of these patients come and afterwards they don't come anymore, and we need to adapt ourselves to this clinic. In Gare du Nord, we are 10 minutes away. They are near the peripheric. These patients are our neighbors, our comrades, those CARU, and in particular, well, it is a real address letter. Hello, I would like to refer you a patient with alcohol, opioids. He's under methadone, but he doesn't answer too well. There is a bit of injections of opioids, crack. There were persecutive and psychotic elements, but he's well follow up. He's treated of his hepatitis C, and but he's doing well. We have the project with him to have a stay in a medical center, but first we need to do the alcohol withdrawal with him. Okay, and what do we say? Yes, of course, we take him, send him to us. The clinic are mostly psychotic patients with this persecution um, experience linked to crack use. That's what we expect because the features of these patients, they use extremely rapid administration vias, and they use repeated consumptions during the day. And we well, there are several manifestations of several events of withdrawal, and they relapse much more than other users, even for users using less strong quantities. Psychotic symptoms, paranoia, schizophrenia, users of cocaine, transient CIP, when they have consumptions. The first situation, which is extremely frequent, is that these patients are non-schizophrenic, but they have transient psychotic symptoms with the XAPA, EGO, medical social hospital form that we distributed to users of cocaine and crack. And what we could see is that most of them describe in the minutes or hours after, within the stories of consumption, you see 55% had already paranoid ideas in the following minutes or hours. 40% described visual hallucination, so it is very much frequent. They listen to the police coming, they have a tactile prosecution, they become extremely jealous of their colleagues or their fellow mates, and afterwards they are able to say that I was talking to the tree, but it was due to the consumption, and afterwards it fades out. What was associated? Well, it was more dependent than those who do not meet this criteria. They use huge quantities per week, more than those who are less frequent users. This is very much frequent. This is within the clinic of patients who come to see us for crack histories. And there is the other situation. They have the feeling that we just do this and this is very weight. Not too many patients, but these are schizophrenic patients who have discovered crack. They are scotched, they are due to massive consumptions. They do not have the capacities to program, to plan, to get out of this, or to schedule the care plans. With a social medical team of Gayat, they animate, they dynamize this room of consumption in a clinical case of a schizophrenic patient who escaped from everything, but she came to be injected the scanon, so morphine, and we succeeded to capture her to have a methadone first and afterwards an oral antipsychotic treatment, and fluoridol, which is the map that some of you know well. And through that, we approached this person, so she would ask for more classical care treatments for those who lose the links, the bonds with the teams. Well, it takes more time, and we needed to adapt our care offer to this clinic of patients, users of crack with these psychotic symptoms. It was like Conjoint du Garin défilé with other prescriptions of methadone since the year 69 and 70. We have up to 900 different patients who come to visit us each year. 600 are on the substitution treatments and 150 on-site supply, not all at the same time, but they are delivered these meds on a weekly or monthly basis, and some are of retarded action buprenorphine. 900 patients per year. We have about 250 who consult us for a problem of stimulo barbiturates, and another more classical hospital with alcohol programs. There were also presentations at the Congress about the involvement between the substances and ADHD. Thanks to the funding of ARS, the demand was saying that these patients, it takes a lot of time, we lose them, we do not put them in the medical care system. We set up a mobile team, psychiatric mobile team for these crack consumers. It is called fluid crack. It is well constituted with an educator and nurse of advanced practices, psychotherapist. I am very proud to say that this team got the Galien Prize Award, which is like the Oscars in France. We needed to follow their parcours de soins and their maintenance in the psychiatric unit. We are following about 100 patients with 6 or 7 demands every month, and there is much social work behind synthesis work with psychiatric teams because they are known by this latter, as well as we will support them and help them to retake psychiatric cares. There are 6 patients who are in hospital every month. Eventually, we are in our addictology unit. It was the adaptation of a care offer. We can confirm diagnostics. They are questions when they are done by medical and social teams. The psychiatrists can visit them. The treatments start, and this allow to give some services to these patients to deliver. We also adapted the residential care, medication care and treatment. This service was doing classically alcohol withdrawal, but taking addictions is very important. It's a huge service. We still have 40 beds. It might seem very comfortable, but there is such a demand, but that it's never enough. There are about 700 in hospitals and 2 withdrawals per year. And 20 years ago it was anecdotal, and now we can find it again in our demands of withdrawal in hospitalization. We have each year more than 50% of our activities done to the benefit of patients with OATS, first plan OATS. And for the first time since 2023, the crack users are overcoming the other patients. So in hospitalizations of withdrawal is medical care. It is a medical service which is very open, and the patients want to be in hospital to treat their dependence. We wrote a paper, and what we could see is that they are a bit older, they are a bit more comorbidities, but patients have understood this work. We did it with the funding of PHRC, dating from 2024. They entered through the in-hospitalization of withdrawal of cocaine or crack, F14 as the main diagnosis, and we followed them to see what they would become. These patients are mainly men, average 40 years, 50-50 between cocaine, let's say, hydrochloride, chloride, classic chloride, and 50% of crack. And finally, the cocaine users would sniff more or less the same. There was a pertence. The injectors that you see here are the injectors of cocaine. The very last line, the average of day of administration per month in the month preceding they come in was 19, so we had many patients who were daily users. Of course, they have co-addictions as well as several medical treatments. Even if there's no ADM for the user trouble of the maintenance or manifestations of withdrawal of cocaine when we receive our patients regarding a dimensional analysis of the symptoms they present. In reality, they have 42% of medical treatments, some antidepressants, and benzo, because when they arrive, they are on alcohol withdrawal. In hospitalization, thus might last 15 days on average, and some of these patients went to post-care services. We will follow up for 3 months, but if we just look the abstinence criteria, we can say that this is extraordinary. Most of patients will relapse, but however, after in hospitalization, the duration before the first consumption is of 1 month. This let us some time to do things with them, and when they consume, they will tend to consume less. When we look at this sample, who relapses the fastest? Well, these are not the worst. The most severe are the injectors of cocaine. Slow administration, when there is the support of family, well, they do a bit better than the others. And when we try to see which were the linked factors to relapse the most retarded possible, once again, it is what I told you. Injectors of cocaine were the earliest, had the earliest relapses, and those who received an antidepressant treatment had longer abstinence rates. For those who accept to stay until the end, they will maintain the longest rate of abstinence. With the ARS region in France, through this program, we benefited from this addressing this derivation to the province hospitals. There was a program to open beds for these people in France. So we thought we would need to prolong this, to extend this hospitalization in France, so they would have time to recover from cognitive troubles, cognitive disorders. Just a short clinical case, patient schizophrenic who accepted methadone. He refused everything. He didn't want to take the treatments, antipsychotic, eventually some severe treatments. He had been in hospitals for 3 to 4 days, and afterwards he left. He was already cared about the social aspects with dispositive essor, which is an arrangement. Well, they could be housed in hotels next to the hospital. It had been done during the COVID pandemic, and this patient had a medical event. He had a pulmonary embolia after infections, and then he accepted to remain more time in hospital. He arrived from medical addictology in our hospital, and we could take him immediately. He accepted to stay more than the 3-4 usual days, and for the first time he accepted to treat his schizophrenic pathology. He could also accept to follow extended cares, first in a rehab center, and he joined it with the RS, with medical socials focused on addiction cares in a province. This patient could benefit from the chain, the origin, with the hospitalization and an intensive care. If you've seen in this clinic of the northern eastern part of Paris, patients have particular features, many dual pathologies. They receive some meds, they are relapses and within the crack users, but they are not the worst, and they need more intensive care treatments and longer stays. We need an important partnership, medical and social. We do it in our team, but it lays on the involvement of many stakeholders in the regions. When we add the somatic balance to take these patients, that's feasible. And for those who do medical care treatments, well, they can treat these patients. I want to thank our sponsors as well as you all also for filling these forms that have been distributed. Thank you very much.
All right, thank you. Thank you for this presentation. I think it was very instructive. Well, I suggest that we move to questions. We have 10 minutes. Any questions in the room? Hello. It's for the last presentation. I would like to know, I have two questions. One of them regarding people who are known as users, but users of multiple substances. I mean, it is difficult to know how much of this substance is used versus the other substances. So from a methodological point of view, this creates a problem because you may focus on one use and actually, or you may attribute one behavior to the use of one substance, but then there are other substances. So this is my first question, how to deal with this. And then my second question is about relapses. And it's rather a comment, actually. I made a film funded by the International Network of Drug Users. It was 2 years ago, and I presented the film here. It's called The Wall of Shame, and it's on the factors of their, having to be displaced from a neighborhood to another because nobody wants them there. And that's why there are certain associations who are there to host crackers so that they're not moving from a place to another all the time. And crack users said that from the moment in which they have some housing, then, if they have just a house, their use of crack is reduced. And actually, yes, they take responsibilities to maintain, to clean the space that they're given, and so on. So it's actually, whenever they have housing, they can project their life towards the future. And if they're back in the streets, if these people go back to the street, they will be in the same condition as before. So I think that housing is very often the key issue for, to avoid relapses as well. Thank you. Thank you very much for these two questions or comments. Well, first of all, regarding this poly or multiple consumption, the reason why we put in place our treatment is because if they're only considered as crack users, then they cannot enter many of the treatment programs. I mean, there are certain programs that are meant for alcohol use or for or programs with methadone, and that's why if we just restrain to crack use, well, they couldn't access many programs. So we want it to be as inclusive as possible. And I think that, well, we have had this discussion actually with other people. You know, if it was only about crack, we could move them from the street and to therapeutical centers, and then it would be easier. But then these users tell us that there's also alcohol and other issues. So that's why our response is always medical, because there is an over complexity. So yeah, maybe we're using a shortcut by saying it's only crack, but yeah, we're trying to provide a global response. And the thing about housing, yes, amongst our cocaine users, compared to crack users have more social problems. They are very often undocumented people because they don't have their IDs anymore. They are homeless. They're very often isolated from their families. So this adds complexity to their situation. So this is the particularity of crack users. But this does not explain everything. I mean, in the clinical case that I showed, it was a patient with comorbidities, with psychic comorbidities and psychiatric major disorder. He had housing, but it was not enough in his case. So maybe for certain patients who have no other comorbidities and they only have the social issues related to being homeless, maybe housing in this case would be the solution, or maybe it would suffice in this case. But, well, we are talking also about patients who have medical complications, psychiatric complications, apart from the use of crack. Hello, Pierre Cadman. I'm a nurse at the care center, and I would like to congratulate the food crack team. I think it is a real added value when it comes to supervising our work and providing psychiatric finesse. We don't have that many psychiatrists around, and we wanted to see the psychiatric situation amongst the people that we host. So I have one question on ASEMAP, because we have 4 or 5 people in our mobile unit of our structure, and almost all of them are users of cocaine, injected or smoked. And there are certain profiles where, in my mind, they may be people who may not follow the care teams because they have quite a violent or explosive behavior. So I don't know if these kind of profiles are the object of your study. Well, thank you. Thank you for congratulating our work. I will convey that to my team. ASEMAP, for people who are non-medical doctors, well, it's a psychotic treatment. It's an oral treatment with 1 weekly administration. And yes, it helps those patients who have a psychotic disorder that is independent, but that may aggravate their consumption of crack. because one oral administration covers several days. The problem is that this has to be delivered by the hospital, so you have to go to hospital. And I think that, yes, we can see these kind of patients that could benefit from such a treatment and from a psychiatric classical treatment.
Merci. Bonsoir, merci pour la présentation. I have a question to Peter Hendricks. Thank you for your presentation and the impressive result with the psilocybin. I have a question regarding the characterization of the responders. If they have a particular profile, those will respond better than others, maybe, and if with psilocybin you change some characteristic on some dimensions, psychopathological dimension of the cocaine use disorders.
So I think the question was if we have any sense as to what distinguishes the responders from those who did not. I don't think that we do. I think that is a question that hasn't really been answered. I would like to know. So clearly some people respond really well and some people don't. And if you look at the depression literature, some people get much better, some people don't, some people get worse. Why? I don't know. I can only begin to guess. It could have something to do with metabolism in the liver. It could have something to do with receptor density in the brain. It could have something to do with psychological characteristics. If I had to speculate, and I think I will because that's more fun than just telling you I don't know. So if I had to speculate, I would gather it's many factors, but I tend to think that the sort of environment, some people refer to this as the matrix, the environment that the participants inhabit outside of the clinic probably plays a much larger role than we realize. Some of our participants, for instance, would have had the support of family, a religious community, perhaps were eager to get back into regular religious observance, so they may have had some structure that allowed them to maintain their sobriety over the long term. Those who didn't have said structure, those who returned to environments that were impoverished, who didn't have many friends, who didn't have access to social support or other resources, who didn't have some structure in their lives that allowed them to maintain those gains, likely didn't do as well. I think that would be the case for almost any clinical trial, however. So I guess the question to me is what's unique, if at all, about psychedelics and the sort of things that ultimately predict response? And I'm very eager to know. That's a great question. I just don't think we have any data there yet, unless I'm mistaken. Maybe someone here is aware. I just don't know of any data that would speak to that, and I haven't looked at that yet myself.
Question, Peter, or I have a couple questions, but congratulations on completing it. This is great to see, and really happy for the results to be out. Two kind of questions or things I'd ask you to reflect on. The first question is urine results and how they might look, which you're probably expecting somebody to ask you, and so hopefully, and then do you have the real quick answer, or is it a longer answer?
Go ahead, and I'll be able to answer both.
Yeah, so the first question is urine results, and then the second thing is, as you're probably aware, there's a lot of discussion now about what to do with control conditions, and I'm curious if you've been following those discussions, and if you think 100 milligrams of diphenhydramine, is the right control condition, or if not, what you think would be the right control condition? Thanks.
Great questions, and for those of you in the audience, Eric Strain and I have known each other maybe a decade now. We've had conversations in Baltimore, Maryland, USA, and now we're having these conversations in Biarritz. It's lovely to be doing this still. So the first question, we would have coded any self-report discordant with urine drug screen if participants said they had not used in the past week but tested positive. I think this was, in fact, a somewhat more conservative approach because some of the work that has been done, for instance, by August Holton, who you probably know, suggests that cocaine can linger in the urine for 10 days or longer. We had 4 discordant reports prior to drug administration. In some of those cases, it was still plausible that our participants were telling us the truth. So we had someone who said they had last used 12 days ago but tested positive. We still flagged that as discordant. We had someone who had used 14 days ago and said that they hadn't used it in the past 14 days, tested positive. We still flagged that as discordant. There was one participant who was clearly not telling us the truth, who said he hadn't used in a month but was testing positive. And we, in those cases, would have given our participants the chance to change their response. So I had some conversations with the Sobels, in fact, about this, who developed the timeline follow-back interview. So what we would have done is said, listen, your self-report is discordant with your urine drug screen. Just remember, there are no consequences for having used, right? There are no rewards for abstinence. There are no punishments for having used. All we care about is the most objective data that we can possibly get from you. Would you like to change your report? Now, in the case of those discordant urine drug screens or self-reports, those participants chose not to change the report, but other than those discordant findings, we, from that point forward, did not receive any more discordant self-reports. Now, I think you're asking this in part because traditionally, in the stimulant literature, there's been a very high reliance on cocaine urine drug screens, especially as primary outcomes, where in some cases you're just taking 3 urine drug screens per week and you code someone as abstinent if 2 or more or all 3 are clean, are cocaine free, because the assumption is often that people who use stimulants just don't tell the truth. It's an interesting development in the field. I don't think it's entirely true that stimulant users are especially unreliable in their self-report. I think the concordance with self-report is around 80%. So they do tend to tell the truth more often than they don't. But I think the prominence of contingency management in the field is such that we feel we really have to rely on those urine drug screens. The FDA in their draft guidance in 2023 even said, listen, we need to back off this reliance on urine drug screens because it's just not tenable to conduct a research study and ask this population to come into the lab 3 times a week to provide urine samples. We have to find some other way of capturing a meaningful outcome. That said, I do think that would be a potential criticism, that we didn't collect urine drug screens all the time. We did rely on self-report, and it's very well the case that some people may have been inaccurate with us. Perhaps in a future study with more resources, we could collect more urine more frequently, but I think that's just too demanding on the participants. To your second question, no, I do not think diphenhydramine was the ideal placebo. We chose it at first because it's over the counter, it's inexpensive. To my IRB, if we had suggested perhaps another controlled substance as a placebo, perhaps that would have been just too much since they were already approving the use of psilocybin for the research study. So diphenhydramine was a nice control because it's over the counter, it's inexpensive. In a study that I'm conducting now on fibromyalgia, we're using dextromethorphan as a control. That could work quite a bit better. But I think the design that I'm really fond of now would include using a high dose, say 30 milligrams or so of psilocybin, and comparing that to a lower dose, say 5 milligrams, and using a unique instructional set in which you communicate to the participants, you're getting psilocybin, you do not disclose the dose they might receive, but you tell them, and I think honestly, the relationship between dose and subjective response is imperfect. Some people do indeed get large doses and report very little subjective effects. Some people do indeed get small doses and report very profound subjective effects. And secondly, the relationship between subjective response and outcome is also imperfect. So, in other words, the participants are hearing, we don't have any expectations or strong expectations about what the psilocybin experience should be like for you. There's no sense that it should be spiritually meaningful or not, nor do we think that the nature of that experience should have any bearing necessarily on your outcomes. My hope is that sort of approach can mitigate unmasking bias, which, by the way, is common in psychiatry. I think Sandeep Nayak conducted a great study. This is also a colleague of ours at Hopkins, finding that in psychiatry in general, the integrity of the blind is almost never assessed. It's assessed, I think, in less than 10% of studies. When it is, it's always poor for antipsychotics, for ADHD medications, but also for psychedelics. So, I mean, one question I have is whether this is a concern that's specifically unique to psychedelics. I think there's some reason to think it might be just based on logic, but I think it's a larger problem in psychiatry, and when we actually assess the blind, we find it's not good. How do we protect that, especially since I suspect that the more effective the medication, the more likely there's going to be unblinding. That was a very long answer, I know.
Pas d'autres questions?
No other questions? Well, we're going to close the session. Thank you very much once more to the 4 speakers for their presentations that were so interesting. And thank you to the audience for the debates, for your attention. Thank you very much. Have a very nice end of evening.